My favourite moment of the month. Morning everyone, welcome to NHS Direct's board meeting. We have, welcome to anyone who's watching online. We have Tim Heyman arriving just in time, perfect. A couple of people have been held up on the railways this morning, so we're still waiting for Chris Morgan and Tim Walton. But everyone else has managed to get here, which is great. I haven't had any declarations of interest today, but I would like to make a couple of announcements, one of which has gone out already and one of which is new. So the one that's gone out already on email internally to our staff is the fact that at the end of this year, Nick Chapman, during December, is stepping down as Chief Executive to be replaced as Acting Chief Executive by Roger Rawlinson, who's our Transition and HR Director. So I don't think that will be a surprise to most people. Nick was intending to step down when 0845 was decommissioned, and he stayed on to stabilise the trust after the major launches of the 111 contracts earlier in the year. I'm going to resist the temptation, and you know me, if there's an opportunity to make a speech, I'm up there. But I'm going to hold myself back from the eulogies, and I'm going to do that next time, which I think would be more appropriate. I mean, all I want to say is that transition will be smooth and well managed, and has been well trailed and planned for. The second announcement, which hasn't been made officially yet, is that I too will be stepping down in December. My term of office as chair comes to an end. It seems an appropriate time for me to move on and to hand over, in this case, to Sue, who's going to take over. She's deputy chairman now. She's going to be acting chair for the remainder of the period to winding up the trust. And so the Nick Joanne team is going to be handing over to the Sue Roger team. And as I said, that transition will be smooth and well managed. But the very important point to make is that the rest of the board, both executive and non-executive, will be remaining in post. So there will continue to be strong and stable leadership for the organisation after Nick and I stand down. Okay, we can then move on. One more thing. Continuing in the tradition of unsuitable confectionery from all parts of the world, I've been in Australia, therefore perhaps not saying anything about the test match. This is just because I've been away, and give us sugar to carry on to give us energy for the meeting when things flag, if they do. Minutes from last time. Any matters of accuracy to begin with? No? Okay. In that case, we can go to the action list, which is mercifully short, and almost everything on it is closed. So the one open item is the corporate performance scorecard, which was being adjusted and amended.
Yes, it will be for when 111 finishes. So the first one will be in January, so that's being considered. It will be considered by the executive team in the next couple of weeks.
That's good. So, to set the scene for this whole meeting, really, this will be the last meeting in which we're looking at performance, monthly performance of 111 contracts. Nick, would you like to just bring everybody up to speed to where we are?
Well, it's
in the report.
As in my report.
Yeah,
so,
exactly.
I think the first thing just to say is that as of last Wednesday, shortly after 10 o'clock, we transferred the last of our 111 services. In that case, it was Buckinghamshire over to South Central. So, as of last Wednesday, we are no longer providing any of the 111 services, and the planned transfer to ambulance trusts has been completed. I think it would be fair to say that it was a bit of a swan in that it appeared on the surface nice and calm. There was a great deal of paddling going on underneath to make sure that calm exterior for patients was what happened. And I would just single out internally within the Trust Roger, who's done a terrific job in leading the team of people in each of the localities undertaking those transfers, with a project lead in each and functional specialists involved. Dave Hudson in liaising with commissioners, Adrian Price in doing a lot of the technical work, and Roger's HR team. So well done, guys, really good. I'd also just in terms of the role of credits, as it were. Paul Watson in coordinating the views and direction and actions of the 5 sets of 111 commissioners, each of whom, of course, comprise multiple numbers of CCGs. So that's no mean task. And with your colleagues in NHS England, Sarah Pinto-Jashinsky, John McIver and Deborah Knight, to make sure that it all worked. So in the end, I think we have transferred in TUPE and in secondments over 500 people who will continue to have a role in providing the 111 services. So I think it's been a good activity. Obviously, happy to answer any questions. Roger will have a chance to answer any difficult ones. No?
That's good.
Okay. So move on to the second item, which is much more unfinished business. We are awaiting formal confirmation from NHS England as to their commissioning intentions. As the board will recall, we had a preliminary letter from Tim Kelsey, the responsible Director General at the at NHS England. We were informed a week ago that the board of NHS England had not disagreed with those intentions, but I am awaiting formal confirmation from NHS England in writing of what they actually propose. I think it would be fair to say I am now getting anxious that it is so close to the end of our staff consultation process, without knowledge of what the arrangements are going forward. It creates additional uncertainty for staff. Will they have a job? If they will have a job, where will that job be? These are very simple, basic questions that we are unable to answer at the moment. There's not much more that I can report at the moment to the board, as anything else would be speculative. What might happen or might not happen, I'm just reporting the facts. That's where we are.
Thank you, John. I'm sorry I was late. What's the date that we need this response by?
Well, the staff consultation closes on the 13th of December, and this board will meet on the 16th of December to make decisions. There is a requirement on us to make decisions as for those longer serving members of staff, they would have 3 months or 12 weeks notice, and therefore without a source of money to pay their salaries beyond March, we would have no option but to declare them as redundant. Otherwise we would be operating outside the scope of our remit, employing people without the money to do it. So we need to make decisions on the 16th of December, and clearly we need really to have consulted with our staff organisations before that, and come to conclusions about what the shape of the world is going to look like. So, final decisions on the 16th, but prior to that, we need information in order to input into the consultation process.
I mean, it's deeply unsatisfactory that we've had to go into consultation without being able to tell our staff what we think the outcome is going to be. So, other than redundancy, if nothing else can be agreed. Yeah. So the idea of having that information, days before we then make a decision, I mean, is even more unsatisfactory. And in the light of the nature of those services and the uniqueness of some of them, I mean, it's a situation of extreme concern, and one that we'll be talking about more in the private session, in which we will, if necessary, be escalating, because it's very serious indeed. It's increasingly serious day by day. Okay.
And I've just reported on the progress to date on in very summary terms in the staff consultation process.
Well, I think, Nick, I don't know if anybody else has any comments or questions.
I just had a comment, if I may. I just wanted to say it's well done on such a complex transfer.
Yeah.
It's, I mean, on paper, everything was right to be, carried through appropriately and properly, but actually achieving it was the key thing, and also with all the partners that had to be brought together. I think it's something I haven't really seen very often done in the way that you've achieved it here. That was the first thing. So the second was, I think I can say quite candidly that we've handed over a strong group of staff to the succeeding organisations who I think can reflect on the time with NHS Direct and perhaps see that as a good grounding for their future and onward development, and to wish them well in that respect. And the third point was to agree with Joanne that it is so unfortunate that we cannot deal with the final phase of our work to ensure our staff are properly dealt with into their futures again. I do think, that I don't understand why that can't be done and why we can't get on with that. But I particularly think the leadership shown by the executives has been exceptional.
Thank you, Peter. I think that's summed up all of the things that I wanted to say. The fact that there's been so little noise around the transfers is remarkable, given the scale of what we've had to do and the difficulty that service is still encountering in terms of it being very new and being taken on by new commissioners and new providers. So it has been a remarkable achievement, and one that people won't be thanked enough for, most likely, because it's not high profile. It's not. I mean, the less attention it gets, the better. And you've managed to do it without attracting any attention, and that's a real achievement.
Good.
Thank you for that. Okay, let's go on then. We've got our corporate performance package, which is this month has a lot in it. Jackie, would you like to pilot us through?
Yeah, so it's the penultimate corporate scorecard, which we've still got the 111 services for October. Thank you. I think performance has continued to be good, in particular for access and volume, but volumes have been relatively low, both for 0845 services and for the DHAT services. I haven't really got anything I particularly wanted to pull out on that scorecard. We do have within the pack the usual sort of national performance, and I just pulled out for interest the national performance as the week ending 17th of November, so this is when the services have transferred over. In most cases, all the there's greens on the scorecard, and where there isn't green, it's sort of 94% and 92% in the northwest for calls answered in 60 seconds, and the abandonment rate is green for all of the services. So again, I think that sort of demonstrates the the services have been transferred successfully. So I don't have any particular question. I don't know whether anyone's got any particular questions. I'm not quite sure how the relevance of the average handling time still being read for nurse advisors. Not sure how relevant that is. Tricia may want to just say something about the actions arising from complaint action plans, which obviously is still read for 111, and what we would do with those going forward.
We've made significant inroads into that particular KPI over the last 6 weeks. All staff have focused their attentions on closing down as many of the actions as we can and handed them over where appropriate, where there's still actions outstanding for what were our employees to their new employer. And we are now in single figures, and I would expect if we were reporting next month that would be green, because the longest outstanding action, which is a core review for a member of staff, is the beginning of September, and that would be completed by this week.
Thank you. My take from it is what this shows is that we handed over services in very good shape.
Yeah.
Um,
And
that-
still in good shape.
and they're still in good shape post the transfer. So that's the really important message. And I personally am not sure that there's any great value in drilling down into these services now that they've been handed over. But I think what they should give, particularly the executive team and the wider organisation, is a sense of real satisfaction that those services held up until the point and past the point that they handed them over. So thanks for that, Jackie. I wonder if I could ask a couple of questions about the Care Connect scorecard, which is page 13 of the DHAS services. I mean, I found that quite difficult to interpret. So there seem to be 3 data points, August, September, October. And if I'm reading them correctly, then the total cumulative number of calls that we've taken on that would be 150 or so, is that right? Up till now.
Because the
to
service
November.
started at the beginning of August,
Yeah,
which is why
yeah.
it's 3 months.
So October would
So
be
low
up
volume.
to October would be 150. So what? And I'm slightly puzzled, given that, why we should have any calls at all abandoned after 30 seconds. It just seems slightly odd. And I wondered about and what I was trying to work out how to interpret the final graph B33 Care Connect cases by type. So I wondered, Ruth, whether you could say something a bit more about this service. And the other question which I thought was important, but which isn't captured here, is the cost per call. So, could I just ask you to give us a bit more of a flavour for what this service is, what these type of cases are, and how much it's costing?
So we currently have a contract with NHS Data total annual contract value is 5.4 million, but we have agreed a minimum take, so effectively we are only the income equals the cost of the service, and
Yep.
if you remember, this service was established from our perspective to protect a number of health advisors around 45 who have been made redundant.
45. So.
Around 45. At the same time as NHS England wanted to introduce a feedback type service
Yeah.
to help patients experience the NHS. So putting the two together, we were able to obviously minimise redundancies and meet their service requirements. Because it's been a relatively new service, it has taken some time to effectively agree what the service is and how it should operate over the time's operating model. And in some ways, the fact that we've had low call volumes has helped us to look at the individual case against what the original specification was, what the operational policies are, to say, are we doing the right thing with this type of feedback, and obviously amend things as we need to. So it's effectively a pilot. It's been piloted in a total of 18 acute trusts, 16 in London and 2 in the North East. And effectively that is the only means by which it's really being advertised at the moment in terms of posters in acute trusts, providing the public with a range of channels in which they can leave feedback, whether that's on Twitter, Facebook, telephone, email. So we are disappointed by the low volumes of contacts, as are the staff who are feeling particularly frustrated.
Yeah. And what do they do when these calls aren't coming through?
Well, we've been able to, as I say, because it's a pilot, continue to update policies, refine policies as we learn more about different types of contacts, undertake training, get them involved in some of the development work in terms of the service, because obviously they are dealing with contacts who are well placed in informed development, but otherwise not very much.
And so do we have a cost per call?
Not as yet, no. Because around the setup of the service. So, for example, we have procured a CRM which supports the caseholders in terms of logging contact. One of the things that we have been able to do is offer the capacity to support other services in the system. So the customer contact centre and general inquiries line, which is the new NHS England public contact approach if you have a question or an issue, is run by Health and Social Care Information Centre. And with all of the commissioning changes and rationalisation of contact points, they were unable to meet the demand coming in through that route. So we were able to help them clear a backlog of cases that had built up over a 2-month period. So we cleared that in 6 weeks. And we were in discussion with them about using the capacity to take the email traffic that's currently coming through that route.
So one final question for me, and then I won't perpetuate, I won't drag this out too far. But what is that graph on cases by type? What does that mean, and what kind of calls are coming in?
So cases by type will include whether or not it's a complaint or feedback, whether people have a question that needs answering. So it's just the way that we log the different types of contacts that come in. And a lot of the contacts are inappropriate. So some of them are abusive. So we have particular policies for dealing with those types of feedback. Some of them are genuine, in which case they automatically transfer to the trust. The trust follows those up. Some of them, unfortunately, are of a clinical nature. So we have policies in place for putting back into.
And what proportion, roughly, of the 200 or so we've had are, as you would determine, appropriate? So, not abusive, not clinical, but they're.
I would say the majority. I don't know that on my head, but looking at the cases on a regular basis, I'd say it's the majority.
I wonder if we could think about whether maybe in December we have some calls. Because I think it's hard to get a sense of what this is really all about. Thank you. Sorry about. I just thought that was. It's interesting. It's new, and I wasn't quite clear what some of that data meant. Anything else on operational performance? No? Okay.
John?
Yes, Tim.
Sounds a bit strange. How many people have we got left now?
Well, that's in the chart, isn't it? So that's on page.
I was building up to the additional question. We're meeting Christmas. We're still running the 0845 overflow service. Are we adequately resourced for that?
Yes.
I know that when we have these periods of great change and transfer resources, it's not always an exact science.
So the 0845 service is forecast to provide for about between 5,800 and 6,000 calls a week, and we are adequately staffed to deal with those volumes.
I mean, the staffing graphs, which are on pages 7 and 8 of the package, which is the finance report, actually, isn't it?
Yes.
Jackie? Let me just ask a quick question about that, because I mean, those give us a really powerful picture of what's happening in the organisation.
November should be lower.
Are those numbers averages for the month, or are they at a point in time?
They will
The
be
end of the
averages for the
Okay.
month.
Okay. So, Nick, you've assured us that we have the right resources for the services
0845,
that we're...
certainly. Yep. And certainly, as you've just heard, I mean, Care Connect is not under pressure from a resource point of view, to say the least, and that we are able to deal with the volumes of calls that we're getting through for Speak to Advisor, the health information and dental services. So, the biggest potential danger is that, particularly with services that are being decommissioned, that frontline staff morale begins to fall.
Yeah.
People start mistakenly thinking that it doesn't matter somehow what performance is like, And I know that with my colleagues on the executive team, we are very clear that one of the things that we can be proud of is that for the last 111 calls that we took, the quality was as much in the forefront of everyone's mind as it was for the first one. And that's true for all of the services. So we'll continue to have our focus on making sure that we do what we've been commissioned to do well and safely for patients. And that message is a clear one that goes out to all the staff.
Thank you, Nick.
Great. Should we go on to finance?
Louise.
Oh, sorry, Louisa.
Just a quick one, just that it would be good to know a bit more about care connect if that's possible. Because it seems to me quite sort of counterintuitive that the numbers are small for what is potentially a very sort of attractive sounding service, and I wondered if that is due to the sort of marketing of that and the access to it, and
Sure,
often sort of being a concern.
Well, it's certainly not down to the capacity, which is, there's wagon loads of capacity.
I mean, do we have any control over
No.
that?
So, I mean, that's the most frustrating thing from my perspective. We have the capacity sitting there. We sit on the Care Connect steering group, and obviously they see the excellence figures, and there has been no marketing nationally. I don't think there's going to be marketing nationally locally because they have no marketing budget. There is a plan to roll out service nationally in the next 18 months, but as yet that rollout trajectory looks like
Yeah, I mean, if other people are interested in it, I think what we could ask for is a very small information package next time. So I think the conclusion was those graphs, given the size of the service, don't really tell us the interesting things about it. And when you think about, I think, something less than just over 10 calls per trust where this is launched over 4 months. I mean, you'd have thought even a couple of posters would might have generated a few more than that. So can we have maybe just a couple of pages of the vital statistics of that service that give us a sense of what we and the commissioners can really learn from what we've done so far. Great. Now the finance side is probably more complex at this stage than the operational side in a sense. So
It is in a sense. We had a very good debate at the Finance Committee on Tuesday, where we discussed both the current position and the forecast outturn position, and the forecast outturn paper is going to be discussed later in the private part of the year. So this report represents, I suppose, the operational position prior to acceptance of the forecast outturn at the Finance Committee. So this is saying we've got a year-to-date deficit of 18.4 million, which is a 4 million adverse variance against the restated plan. However, as part of the forecast outturn, we've now agreed and will be recommending to the board that we do bring into account the 5 million underspend from the Q1 budgets, because we have got legitimate sort of calls of expenditure against that 5 million. So the year-to-date deficit would effectively then be 13 million as opposed to 18 million, which is then ahead of plan rather than behind plan. So the current forecast is that the forecast operational outturn is a deficit of 24 million, so that's about 5 million favourable against plan, largely because of the transfers of the 111 services, because we've transferred out more costs than we're losing on the income side. In terms of trust closure costs, there's still some work to do, because that will depend on which services are going to transfer out or not. So there is still some more work to do on that, but we've been discussing some of the overall costs, and we'll perhaps discuss those later in the private part of the board. In terms of cash, we've got 6 million in the bank at the end of the month, and we've definitely got enough for November without having to call down any more balances from the TDA and the EDC, and that's largely because we are now receiving the income, starting to receive the income for the 0845 contingency for Q2. out of the 5.2 million, we've now received or had promised about 3.5 million. So that is good news from last month when we didn't have any.
Yep.
So no more questions from me unless anybody has got any particular questions.
Does anyone have any questions, Jackie? No. The Finance Committee have obviously spent a lot of time on this and gone through it in detail.
Yeah.
I noticed that in terms of getting money that we believe to be owed to us from local commissioners, that appears to be going in the right direction. But there was one commissioner named, I think, in the private papers, from which we have had no money at all.
Yes, that's
And my question there was, we might want to discuss this in private rather than in public, is there a dispute going on? I mean, are we at risk there? It might be something we want to discuss
so
later.
it's relatively small.
Yeah.
So it is at risk, and we will be in dispute, but we escalated it now.
Okay, good. Yeah. So, in your view, are we significantly at risk on that income overall? Not from that one commissioner, but from...
No, so there are some risks on it on income, and we may require support of TDA and NHS England to make sure we get it in. But at this stage, I've got no reason to believe that we won't get it.
Okay, very good. Tim?
I don't think we should go into specifics here, but at the Finance Committee we did look at the range of outcomes that might happen and those things that have to be addressed to get us to the right end of that range. And we also took the forecast that we've currently got as a proven view, looking at all those things that need to be done. And I think going into those in detail is probably an issue. That's why we had the finance meeting in private, actually, because some of those are commercially sensitive. And we can pick them up later.
Thank you very much. That's great. Okay. If there are no more questions for Jackie now, we can then move on. We have one item in our strategy section.
We do.
Which is I think the rationale for this was for us in our position, given our unique participation in the urgent care scene, as we have been through multi-channel 111, multi-channel 0845 and 111, to reflect back on some of the reviews and conclusions that have been published in the last few weeks, and to try and make some sort of contribution to that forward planning from the unique experience base that this organisation has to offer. Jackie, is that with you?
No, it's me.
No, it's you. Okay.
It says you, but it is actually me. Yep. So this is a paper that Kat, Tricia, and myself owned, and what we've tried to do here is, as factually and as dispassionately as possible, present the key kind of salient features of the debate that's been occurring on the management of urgent emergency care, and to draw out what we think are the messages, the consensus that's already there, which I think, if you wanted to be in a sort of cup half full kind of world, there is now, I think, a real consensus that telephone, mobile and web-based information, advice and assessment has a very positive contribution to make to the management of urgent emergency care. And I think that's a very positive consensus. And secondly, slightly less positive, but in a forward-looking sense could be positive, which is that 111 can play a more significant role if it is enhanced. And certainly in Bruce Keogh's report on urgent emergency care, he begins to spell out what some of those enhancements should be. And particular at its sort of the nub of it is a greater involvement of clinicians with access to meaningful contemporaneous clinical records to be able to help advise patients. I think it's significant that Bruce Keogh's report talks about the promotion of self-care as an objective in itself, and really that is the first time that that's properly been recognised in a 111 context. So, I mean, just drawing on what you said, Joanne, we are now in a position, some might say, to give gratuitous advice because the one thing that it's not any longer anything to do with is the forward strategy of NHS Direct. We are simply giving our advice to others that may or may not want to listen to it. And what we're trying to do in this paper is to draw together in as reasonably brief and coherent a way as we can what we think the big salient features of the additional things that perhaps should be paid more closely, more attention paid to them. I think we could have written a lot more, and certainly as one goes down in terms of levels of detail, there's a greater and greater degree of granularity that one could get into. But this paper tries to stay at a moderately summarised level. I won't go through each of the areas where I think there would be advantage in continuing focus, because they're set out in the paper. But certainly I would hope, arising out of our discussion today, we could effectively communicate this to those policymakers that are interested in the development of 111 in order to just give ourselves the satisfaction of having passed on our advice, I guess.
Well, hopefully having had our advice used in a positive way for the benefit of patients in the NHS.
That would certainly be what we would hope.
Especially in the light of what is predicted to be increasing pressure on A&E and the emergency care system. Okay.
So I don't know if Tricia or Kat wants to add anything.
Well,
Kat, sorry, Tricia,
No.
you can hang on a minute.
I mean, I thought that there was an obvious sort of recognition and need for kind of a large-scale whole system approach to the way that we're going to drive forward urgent emergency care, which of course is welcomed. In the report, I was a little bit disappointed at the lack of reference to non-remote ways of delivering urgent emergency care.
So, which report are you referring to?
Okay. And although the symptom checkers were referenced in the report, and the report made big play about the use of pharmacists in terms of delivering care in the community, that just feels slightly in contrast to the fact that Chimes and so on isn't going to be commissioned beyond March 2014. So I just felt like there was some conflict there. There was a lack of recognition of the services that NHSD could actually provide that were entirely complementary and in addition to the 111 services.
I agree with that, Tricia.
My focus is particularly on skill mix.
Yep.
Of the services that we're delivering. We have done a great deal of work to go beyond just nurse assessment, adding value to the clinical aspect of care delivery in the remote healthcare setting. So developing our health advisors further to be enhanced practitioners with the assistants, using pharmacists and using dental nurses, and all of that needs to be considered in the future delivery of urgent and emergency care via the 111 service, and it is a shame that those skills are not being recognised at the moment.
Anything else? Tim?
The bullets that we've got in the summary, are those our bullets? Or
Yes.
Yes.
Can I make a comment about that, please? I thought that develop NHS pathways was a bit soft, actually. As I understand it, pathways have not been designed to deliver self-care. It sounds like redesign is a better word. I'm sorry, not semantics here, but I think develop implies that it's mostly good and you can tinker around a bit and it'll be fine. If it really has not covered a specific large area of care, then it's more of a redesign than a development. My other comment there with pathways, I shouldn't say this maybe, but are we talking about the software or the process? And I think we're talking about both. And I think we ought to say both, because when people say pathways, it can mean all sorts of things to all sorts of people. That was my first point, so I don't know whether we want to think about that. And the bottom one, utilise NHS Direct's accumulated IPR. A lot of our IPR is in people's heads, and a lot of it is now dispersed. And I don't think we should mislead people is that there's a nugget of IPR still there. I mean, I can't judge how much is remaining or still still leverageable, if that's the right term, but clearly some of this IPR has been lost. So I think we ought to think about how much of that IPR we've protected and gathered and can be available for the future use.
Thanks, Tim. Louisa.
And I would second that, and I wondered if some of it still existed in some of the board papers, so some of the work around showing the impact of the move to 111 on services around access to sort of psychiatric support, for example. And I felt we were quite generous saying, referring it to Sir Bruce Keogh's vision. I thought that was quite generous because actually there was absolutely nothing here that I felt was any different or new, and was exactly, I think, what we had been advocating to the department, a long time ago. So it felt to me that this was very much what we had asked for, and felt was in the best interest of patients. I think the one thing that may be more amenable to Bruce Keogh's, maybe in his gift, is the link, the sort of link to meaningful patient-level data, which he was obviously in a position to push for.
Thanks, Louisa. Tim, were you?
Well, I think my thought on this is that it's a very great summary of what's going on, but why? Because who's going to listen to what we said before?
Yeah.
It's not clear what Bruce Keogh's report has done that has really paid much attention to us as an organisation and our views.
I agree. I think that's the question.
It's rather sad, but I just wonder whether the executive had communication strategy in mind for this.
I think that's exactly the question. So this board can carry on talking to itself, which we can do very well indeed. But the fundamental point that in moving to 111, a decision was made which effectively transformed a multi-channel service designed to maximise self-care into a telephone-only signposting service designed to get people to face-to-face care as efficiently as possible, and the inevitable consequences that would have on the workload for face-to-face services. But that is a very old message, and our view all the way through this process has been that 111 would need to be re-engineered into something more like what NHS Direct has always done, which is multi-channel clinical advice, maximising self-care. And the question now, I think, for the board is there any value in trying to communicate that again back into the system? Perhaps the next point was that there is an emerging consensus that something like this is needed, and that Bruce Keogh is talking about enhancing 111 or beefing up 111 and some sort of phrase like that.
I think is the word.
That given that conclusion finally seems to be emerging, what more can we do to move that on? Steve?
Well, I think the only way that's going to happen is if members of the current executive begin to bid with some of the parts of the organisation that are going to developing this further. It's not going to happen because the paper's been posted out to somebody. But if members of the executive are attracted to working with Trust Development Authority or NHS England, then that in itself could be the catalyst to ensure that IPR, the useful bits, aren't lost. But I can't see any other way.
So it's about people taking the accumulated knowledge and working with the organisations that have an influence into the future.
I mean, I'm not sure I have an answer for the how particularly, but the way that this report is expressed is exactly the direction in which local government is going with NHS locally. So self-care, early intervention, and people staying longer, healthier in the community, or being able to manage their own long-term conditions. Now those are all the things that we have got in West Sussex, but it's also elsewhere. And it's because public health has been brought into the centre of that debate as well, that has helped to get through that sort of problem that we've had in the past of trying to make people not dependent but more independent in their lives. And although that's slightly a political message, it's also a practical message to people. I mean, I've said this before, I don't know quite how this work can be interpreted in a local sense, but I know people would love it. This is where they are, this is what they want to do, this is how they must go. And there isn't the resource to do anything else, actually. They actually have to do it this way. So it's not, not even a, well, do I like it or not? It's a sort of clearly you've got to get on and do it this way. And so I leave that in the air to some extent. I think individual connections that people have on the ground will help a lot with this. Public health has a big leadership role in taking this through, and I mean there are connections there, and they are objective people who are evidence-based. So they actually look at the evidence before they open their mouths about how they're going to take something forward, or they will put in place research to actually find that evidence. And that's something I've learned from my public health colleagues most recently. So maybe that's a line. There is the National Public Health Authority, and that line might be possible. Plus, there are local strands of that as well. So they would have empathy entirely with this work. Anyway, sorry, that's.
I think you're right, but the levers are very weak.
They are extremely weak.
I mean, I think in response to Steve, I'd say that some of this stuff is national. I mean, what the direction that Pathways takes, for example, isn't going to be determined. I mean, one of the distinct features of Pathways is how insensitive it is to the needs of the organisations delivering the service on which it is based. It doesn't have the accountability to its, if you like, customers or something, people we would think of as customers, which aren't customers in the current environment. They are users. So some of these messages ought to go into, are not there. Some of these things, the development of Pathways into supporting more clinical advice and advice that keeps people at home and enables them to self-care, is something that won't be done locally, it will be done centrally. So I think it's both people engaging, and it's also about trying to get some messages through at the centre, which, Nick, I think perhaps you're best placed to do, through this paper and any other conversations you want to have around it.
Well, yeah, I mean, if I respond to some of the things being said. I mean, I said in my introduction that this is slightly hanging in the air as a bit of gratuitous advice based on what is now, I would maintain, as lacking in any kind of self-interest as an organisation. Clearly what we're trying to do is to evidence what we think others are saying and correlate that with our own experience and try and focus that into an interesting, maybe softly spoken, but I think our experiences has been that more aggressive forms of advice haven't worked either. So this is a softly spoken, and when one gets to the point where the people one is trying to persuade starts espousing the thing that we've been advocating as their own idea, then that's the point at which you think you're winning. And if that means that we say, thank you very much NHS England, you're doing exactly the right things, you've got the right focus, here's a bit of extra help in the direction that you've decided to go, well, I'm willing to eat that humble pie. So certainly it would be my intention to communicate the essence of this paper to those that are charged with taking forward the policy on 111 as a genuine attempt to try and distill some experience and some helpful advice for those that are going to be charged going forward with this. I think there's a lot still to be played for. There is no new specification of 111. There is an enormous amount of work that needs to be done to nail down what it is that that new specification will be. What do we mean by multi-channel? How will pathways be developed and geared towards achieving objectives? What data should be gathered to help steer the process going forward? I mean, there's a huge amount to be. I think we're just at the start of redefining 111. So I think a softly spoken, positive, aiming to be constructive kind of paper and communication in my last 3 weeks is certainly what I would aim to try and do.
Good. All right. It's the best we can offer, I think. Shall we then move on to the governance and compliance section of the agenda? Alan, you're going to steer us through the board assurance framework and the risk register.
Yes, thank you, Chair.
Smoothly and quickly, I think.
And I will be quick. Just 3 quick comments I'd like to make to introduce the paper. Firstly, just to remind everybody that this reflects the October end position, and therefore at that time only one of the 111 transfers had occurred, and that's why the risk is still live in this version of the document, and obviously will be adjusted next time when we have November's update. Again, I think I said this last time, but there is increasing emphasis in the risk register on the importance of a safe transfer of the remaining services to a successor organisation or organisations, and we've spoken about that today already, and I'm sure we'll do so in the closed part of the meeting. And finally, for me, with those comments in mind, it's hardly surprising that the highest residual risk areas reflected in the October position were firstly the 111 transfers that have now been safely secured. Secondly, the ongoing provision of the 0845 contingency service insofar as the challenge of downscaling the workforce and the coverage provides, and Nick made reference to that in his report. And finally, the financial position. Jackie has given an update, and we'll be speaking again about that as far as the forward position is concerned. But at this stage, the key risks remain, I think, as making sure that the income continues to be recouped, and there are good signs that that is happening, and securing funding agreement for the eventual decommissioning costs of the organisation. So that's really my only comments to cover this paper.
Thanks, Alan. Are there comments or questions to Alan on that very nice, succinct encapsulation of the remaining risks that we're managing? Okay. We can move on to committee feedback. Sue, we've had a bit of a governance committee, and you've been really well organised around it, so we've got your minutes as well as your feedback.
Yes. In fact, I think I gave feedback at the last meeting. Yes, because it was immediately before the board. So I don't think there's anything more to add on this, as whether anybody has any questions.
Okay. Finance Committee then.
Tim. Thank you.
We've referred already to some of the stuff you've been doing.
I think we have actually, and I think we'll keep it to the private session. I don't think there's anything to add unless Jackie wants to prompt me.
Nothing.
But as I said before, we have explored the range of outcomes, and I think that's really important. We'll go into the detail of that later.
Okay. Fine then. So we're into the stakeholder section of the agenda. Are people happy to keep going? Yeah? Okay, good. So the first item is a verbal update from Roger on trust engagement visits, and in particular those relating to the staff consultation. And then we've also got agenda item 11.2, which is the paper that didn't have a title. That's the post-Francis listening events paper from Tricia, as well as the patient experience calls. So should we address them in that order? Roger, are you happy to do that? The consultation visits first?
Yes, I'll be fairly brief, but I'll go into a little bit more detail. And than Nick did in his Chief Executive reports, just to update colleagues on the point we've reached in the consultation. You approved the consultation document at the last meeting, so that was the 28th of October, and we duly launched the consultation on the 30th. We've had, excuse me, 20 launch meetings since then. They were all completed in the first 10 days. Excuse me, I haven't got a cold, so I don't know why I'm doing this. They were all completed in the first 10 days of the consultation, and since then we've had what we've described as functional meetings. So the finance team have had their meeting, HR have had their meeting, and also we've had service meetings. So we've had 3 ways of launching the consultation so that colleagues understand their role in it. We're now starting the one-to-ones. We had expected by now to have more information than was in the original consultation document.
Absolutely.
And we haven't.
It's very regrettable.
So although we will be starting the one-to-ones with groups of staff where their fate has already been fairly clear, we are also going to have to consider the one-to-ones carry out the one-to-ones with those for whom their fate is not known. It also calls into question the quality of the board seminar on the 11th of December, when we were going to work through some of the themes of the consultation. If the themes are largely, we actually don't know what's going to happen yet. One good piece of news is it does look like we're going to know the identity of the provider of the appointments line service before the end of the consultation. So we think that's going to be the 7th or 8th of December. So whilst we might not know which sites they're going to use going forward, because of course we use 3 sites for the appointments line at the moment, and the expectation is that they may not use all 3, at least knowing the provider means we can push the thing forward a little bit. And it does call into question the quality of the paper that we'll be bringing to the board on the 16th. And I guess the only thing we can say at this stage is that the default position that we are required to have at that point is that all employees who don't have a distinct future will become redundant, and although it is possible that we may be able to rescind redundancy in the new year, that's an unsatisfactory state of affairs. So that's where we are at the moment. We've launched the thing, but there hasn't been any new information to share with colleagues.
Can I just ask a couple of quick questions, Roger? In relation to a one-to-one meeting,
yeah.
I mean, isn't that just an extraordinarily difficult thing to ask a manager to do, and an extraordinarily unsatisfactory thing for an individual staff member to have when neither of them knows what actually the option is going to be?
Well, what we do have to do is to introduce the default position for colleagues who we thought may very well have a future. If you take, for example, speak to advisor, nurse advisors, we're now going to have to introduce the possibility with that group of colleagues that redundancy may very well be on the cards, which the expectation wasn't at the beginning of the consultation. So it is having to shift a little bit.
And do you have top of mind the number of people with whom, for whom redundancy is the only option we're going to be able to discuss?
Yes, I mean very roughly, it's about at the beginning of the consultation, it was something like 300 against 200 who will probably carry on. That, of course, may well shift. But may not. I mean, this is not over yet. Let's not come to the conclusions until those conclusions have been reached.
The conclusion is we don't have something that we can put on the table.
Exactly.
That's the conclusion, and it's very unsatisfactory.
Yes.
And
we are on an inexorable timetable.
Exactly. The clock is ticking. Steve?
Sorry, I was going to say, are we going to discuss that in the private section?
I'm sure we are.
About what we're going to do?
I'm sure we are, but I think in public we should
just
recognise how difficult that is for staff and for people.
We're simply highlighting that we do not know what NHS England's commissioning intentions are. We've not had those confirmed, and therefore the impact is that for staff whom we would, and their organisations, we would wish to consult about real and concrete options and implications, we're only able at the moment to have speculative conversations, which is not very helpful, and a default position, which is if we carry on with this uncertainty at the end of the process, there is only one outcome.
Yeah. Which we will have to report 3 weeks today.
Yeah. Understand. Okay. Any questions for Roger? No. Thank you. Joshua, would you like to give us the background and the key headlines from the Prost Francis staff listening events?
Thank you, and I apologise for the paper not being titled. It's titled in Clinical Governance, but lost obviously
lost its title
and it's
translation.
transitioned to the board papers. So thank you. So board members will remember we have been undertaking listening events in order to address our response to the Francis report, the Department of Health's response to the Francis report, and executives have gone to all of our sites and had engagement meetings with staff, and particularly focusing on compassion and empathy and the quality of services that we deliver to patients and what their views and feelings are with regards to that. And I particularly enjoyed these events. It was a real opportunity to hear from grassroots upwards of the services we are providing, what staff feel about it, where improvements can be made, but particularly for me it was where staff did actually state very clearly, they loudly and proudly stated they enjoyed working for the organisation. They truly believed we put the patients at the focus of what we do, maintaining the quality and safety of service we deliver. They recognised was a key value that the organisation had at the forefront of what it did. And we equally supported staff to provide that good quality service to those patients. However, inevitably, as you would expect, and certainly I believed it reflected the significant changes and challenges all of our employees have had over the last 18 months, they did clearly identify where improvements could be made. And you know, the particular details of that are within the body of the report. The key focus, particularly for the NHS 111 employees, was the focus on driving down call length, average handling times. They understood why it was important, but equally they felt on occasions that they were under particular pressures to meet a target rather than truly engage with patients and be able to give them what they wanted. However, those comments in relation to the 111 service we will be sharing with the current now providers of 111 as we will share from this report. This is what the staff who've now moved over to them believed where improvements could be made. But overall it was a very positive experience, and I believe we do deliver compassionate and empathetic care to our patients.
Thank you, Tricia, that's reassuring. But there is lots of substantive comment in here. Has anybody got comments or questions around the paper? So I will ask the question then. So it seemed to me that there was a natural and healthy mix of views in here, but some of it was very explicit and probably ought to be actioned. I mean, for example, a comment that pathways sends diarrhoea and vomiting to the GP every time, but actually they could be home care. So there's a whole range of very specific things. So what are we going to do to sort, distill, organise those comments and make sure they get fed in to the right part of the system now that it's not us?
Yeah, so there is an action plan that's arisen out of the whole of the Francis report where we did our initial review, and an action plan that's arisen out of these listening events. So there will be key clinical people between Kat and myself sharing information with pathways, certainly through the request for change process, sharing information with future or the now providers of 111.
Yep.
So there's a whole action plan that's arisen out of this and will be monitored right through to the 31st of March.
Yeah. Including some comments here that will go to the new provider of the appointments line, for example.
Yeah, all of them will be shared with the appropriate commissioners and providers as and when they are identified.
It sounds like rather a worthwhile exercise.
Yes, it was.
Brilliant.
John, just on the digital services, we already have an website function where we collect all this information every month. We review it and review the actions. So that's already in place for all of the non-111 services.
Okay. Peter.
Yeah, I wanted to just say a little bit about this listening to patients comment that emerged. I saw that in two ways. I think one way is listening to patients when they're critiquing how we've done and where they feel we haven't performed well and where they have ideas about improvement, or we've handled their complaint badly, or they don't think we have listened to.
Yeah.
I think that's one element. The other element, which is about how we deal with individuals at the time they call. There is a value and a great skill in being able to be concise and get to the point about what someone's ringing about, so that you can actually deal with it quickly. And if you can do that and properly direct them to the right place to go or give them the right advice, you can get on quickly to the next one, which means you can actually deal with more people. And so I do think it has to be viewed in that sort of context. But it is quite interesting about the empathy points that come out about tone and warmth, and which I do agree with. I think the way you go about your business is important. But actually getting on with it also is equally important professionally as well. It's you want to get on with it as much as you want to have a chat with someone, which is nice. But there are other ways of doing that, I think, perhaps. Anyway, I just thought that might be something which certainly I've had that elsewhere with these sorts of events, particularly on safeguarding, where it's actually getting people together to really ask them in some deep way what do you think of our services and how do you think we can improve, adds great value and has to be done properly, and you have to want to do it as well, but it's not during the clinical conversation, it's outside of that.
Louisa.
I was just at the kind of governance committee looking through the paper. We were really impressed with it and really pleased to see it, and felt very much they reflected the impressive way in which staff always have really sort of insightful views about what they're delivering. This is never a sort of brainstem service. This is always something that people think about and care very, very deeply about, even in the midst of extraordinary turmoil. So we were very impressed by that.
Tim.
Yeah. Firstly, I think this is excellent. I know that all trusts were asked to respond to the Francis report. I think we've done more than that particular letter, so that's great. Just a question about where it's going, because there's some real nuggets in here, and obviously it's got to go to the new 111 providers. But my attention was drawn to some of the ICT stuff. And some of the reflections from here clearly need to go somewhere. So I think could you address the more general, the non-111 specific stuff, and think about the circulation of this report and who should get it? Because I think that's very valuable.
Is that in your action plan?
Yeah, it is in the action plan, and I've already had raised issues with Alan, and the ICT team have been very responsive internally in addressing some of those issues.
Thank you.
Thank you. So I think there have been a couple of really interesting. I think we've all found this very interesting, and Louisa expressed well, I think, a really important point, that the recognition that at a time when the future of the organisation has been has not been for a long-term future, our staff have still been able to think about the service that they give from the point of view of the patients, and have been able to put their own personal futures to one side in order to remain really very focused on the quality of the service, and that's fantastic to see. I think there is a very interesting and rather subtle point that Peter alluded to. So we hear a lot of people saying pressure on us to reduce average handling time reduces the quality of service. Potentially it does, but it doesn't need to. And maybe we could have been better at providing our staff with the training them and giving and supporting them and developing them with the skills of having a highly empathetic, effective call in a very short time. And that is because I think that with the right skills, actually our calls would be better as well as shorter. And maybe that's something that people get from experience. But it's a really important point when you're trying to deal with very high demand at very high quality. And you want to give people, and very often patients would rather have the answer more quickly if we can do it in an effective and empathetic way.
And we did have those debates in the sessions. They were exactly the discussions that were happening. One member of staff would say, I need to take all the time I need to take, and another member of staff was saying, no, I listening to the calls when the patient's frustrated at the call length being too long.
Nick?
I just, I mean, we plenty of times have said a long call is not necessarily a good call. I just wanted to draw out the fact that what's presented here, of course, is the full spectrum of views. And absolutely. What I'm sure none of us are doing is saying one particular statement is generalisable across the whole of the staff opinion, which it isn't. It clearly isn't. Well, we've expressed all of the views here.
And we have a rich and diverse set of views.
Yes, absolutely.
Some of which, perhaps more content specific, one can generalise, and some of which you can't.
Right.
Thank you, Tricia. That's very helpful, and it's good to know that there's an action plan that goes along with that will pass on to people who have responsibility for the service going forward. Okay. So we had a CD with a patient call, 2 parts of it. I see on the agenda that we had a call for complex health information and medicines inquiries. I personally didn't get to hear that call.
No, it wasn't on the CD.
It wasn't on the CD? No. Okay, fine. So we don't have that one. We did have an 0845 contingency call, but unfortunately there was a problem with the access code. Not everybody had a chance to listen to it. No. So can I just ask, who has not been able to listen to that call? Okay, so there are only 3, so the rest of us have heard it. Good, okay, so we can have a sensible discussion about it. That's great. Tricia, would you like to just quickly introduce it?
Yeah.
And then I'm sure all of us who listen to it have comments on it.
I'll try not to preempt those comments. So this paper provides background in relation to a call made to the 0845 contingency service made in September of this year, and it was regarding an elderly gentleman who had been discharged from home having had which 2 decades ago would have been major surgery and had probably been in hospital for at least 2 weeks. This chap was in hospital for a day, overnight stay for the removal of his kidney. He'd been making good progress at home, but then took a turn for the worst and was experiencing some severe symptoms of vomiting, which was obviously causing some distress to himself and his family. He made the call to our 0845 service, which was initially prioritised by a health advisor. And I remind board members that these staff in the 0845 service, quite a number of them are new, and I felt the health advisor undertook quite a reasonably prompt assessment and come to a decision to, quite rightly, even though the system had said it was a low priority call, to get some support and clinical advice and pass this on to a nurse. The nurse then undertook a clinical assessment which was on the call recording extensive. the actual clinical assessment, the nurse came to a decision that yes, the gentleman needed to be seen and assessed physically by a GP within a matter of 5-6 minutes. However, the remainder of the call was considerably lengthy due to demographic details, finding where the GP was, where the patient themselves was, and then I knew the nurse was actually struggling to find the technical link that would have connected the patient to the out-of-hours service that she knew the patient needed to get to. But because this was through to the 0845 service, due to the maintenance of the technical links not being 100% across all the geographical areas, the nurse couldn't find this technical link to seamlessly transfer the patient to the out-of-hours provider, which resulted in the nurse eventually advising the patient to dial their out-of-hours provider and gave the number for that. And I think the call actually highlights the problems the staff are currently dealing with in the 0845 services. From a patient experience perspective, it is poor if the patient needs to be referred to a face-to-face service because there are not the connections to seamlessly transfer the patient. And what the family actually comment on in their feedback was they felt the nurse assessment and the call handler assessment had been right and appropriate, but they were highly dissatisfied with having to go through a secondary assessment when they did ring the out-of-hours provider, and then the very poor service, as they described it, of the visiting GP due to the delay in actually accessing the right address of where the patient was.
Thanks, Tricia. I think that's a good summary. Does anybody else want to say anything about it? Well, I'm happy to weigh in. Peter, would you like to go first?
Well, yeah, I think this was, having been a connoisseur of a number of the calls now over a number of years, I suppose the thing that I note now that I wouldn't have noted before is the agonising time it takes to get to a decision, and the fact that in this case anyway, the call handler was talking to the daughter-in-law, not the man in the room, as it were. But the questions and answers were, for me, were unsatisfactory because they were quite fast. There was very quick fire question and answer sessions, and I wasn't convinced that always the answers were clear, and therefore how you could interpret them was, other than the generality of what it was about, I think it was clear what it was about. And going through the algorithm compared to the common sense sort of pragmatic thing that was obvious from the conversation. Nevertheless, they got to the point where it was handed on. You're right. But I'm just saying the bit with the nurse and moved rapidly, as it says in the text, to the point where it's clear it needs to be moved, there needs to be a call. And then there's a lot of faffing about, to use a technical term, which just was almost intolerable. It just felt sort of, I was squirming almost about it all for all the people's concerned, and I realised there were technical problems with it as well. The other thing which I just thought happened was that the nurse tended to mix advice with what you should ask the doctor. So this is what I think you should do now, as it were, as against this is what you should talk to the doctor about. And there was sort of in and out of that sort of conversation, I felt. So it did make me wince a bit, I have to say. And it was one of those events where everyone was, I think, on best behaviour. It was a fair and reasonable conversation. When the nurse spoke to the 82-year-old gentleman, I mean, they had a reasonable conversation, I thought. But then when she went back to the daughter-in-law, it sort of got lost in translation. So,
thank you, Peter.
There we are.
Yeah. Further good points. Louisa?
Yeah, I'm not agree with all of Peter's points. I mean, in the front as well, I was sort of surprised that we started off by saying that we sort of got to the decision quite quickly, because it took a long time. It really felt like it took a long time to get the decision. I agree there's that knowledge, but too like. And it was really interesting because it didn't feel like there was a clear direction of travel. I thought it was messy all over the place, and I couldn't quite work out, why it was taking so long to get somewhere. And it felt a real disconnect between that situation and the real sort of physical, non-virtual sort of life. So I thought that was an example of left of call unrelated to quality of service. And that if you could get to the nub of what went wrong in that call, we might have sort of it would be possible to deliver something to an outcome more particularly effectively with that sort of compassion, because it did feel all over the place.
Nick, then Steve, then Roger, then Tim.
Two things that it reinforces for me on the 0845 service, the faffing about that we've referred to, as Tricia rightly said, the technical link. This is where both the GP out of hours organisation and ourselves need to maintain the technology and the data involved in order to be able to pass messages electronically. And where that doesn't occur, we should not be doing assessment. We should be advising the patient to phone 111, provided there's a 111 service active in the area. Currently, about half the calls that are coming to 0845 are coming from areas where 111 service is up and running, and we really ought to be more and more disciplined in making sure that we don't carry out detailed assessments and we simply advise the patient to redial 111. Otherwise, we'll get more of the faffing around, and actually the result for the patient is they have to go through the whole process again. So we'll do a very quick safety assessment with the health advisor to check that a 999 outcome isn't the immediate priority, and assuming that is okay, then to pass the advice to the patient to phone 111 rapidly is, I think, what we should now be doing.
And we've introduced exactly that to the system.
Steve?
Well, maybe I don't understand the technicalities of how the sort of conversation went on, but it seemed to me that once it was established that the person had a nephrectomy, that there was never going to be take a hot water bottle and go back to bed. It was always going to be either a doctor or an ambulance, wasn't it? So it just seemed there could have been a fast track way of actually coming to that conclusion. It just went on forever. I was sitting there thinking,
I know the answer.
I know the answer. So I know it must be difficult. You're talking to call handlers, but it just seemed that part of the conversation went on for far too long. And I'm sure the call handler was doing everything they're supposed to have done, but it just seemed to go on forever.
Yeah, Roger.
So I was interested in we're running this service for another 3 months. So what can we learn from this? And
exactly.
And Nick has highlighted, I think, half of that. The other half is we will still be doing this where there isn't a 111 service. So is there stuff we can do to improve in those sorts of areas where we're still doing it?
We need to make sure the technical links are up and running.
So
there is no excuse in the areas where the 111 service is not running. The out-of-hours organisations must be populating the technical links, and if they're not, it's a serious untoward incident.
Indeed. And I just wonder.
So should we be capturing those as SUIs? Because there's nothing in there about that.
The technical links are in place for the areas where we are formally still commissioned to deliver 0845 services, because 111 is not operational in that area. So they are in place. I don't want anybody to think that there's serious untoward incidents.
The only sorts of
around
problems
the
that you do get, Tricia, is on a bank holiday weekend, people forget that Monday isn't a normal Monday and it's an on-call Monday, and the rotas don't match. It's that sort of problem.
And there are systems and processes in place should that arise in order to get in touch with the operational link in the out of hours provider to say either your rota's not uploaded, so upload it, but I want to assure the board that for the services we are commissioned to deliver 08454, because 111 is not operational, those links are in place. It's when a patient who is in a 111 area rings 0845,
which is what happens here,
where there are problems. Yeah.
Tim.
Not sullied by having listened to the call. The interest to me here is this idea that you have a one-night stay for a major operation, and then apparently you don't have a telephone number to call the ward or the team. And I wonder whether this shouldn't be feeding into our comments on urgent and emergency care. Because had this been a day case, the patient would certainly have gone home with a paper which says, if you have problems for the next few days, call this number. And there would have been a 24-hour nurse or somebody on leave who would respond in the sense perfectly reasonable to be vomiting 2 days after your nephrectomy, or no, it isn't, you need to see a doctor, or come see us, or call an ambulance. So I don't think 0845 or 111 should have been involved in this at all. And I think that's rather important as the nature of surgery changes to reduce average length of stay, nature of plan surgery.
Yeah, I agree with that too.
Good one.
Ruth.
Trish, was this a conduit health advisor or nurse advisor?
Yeah.
So do we have a process then for sharing this?
We do indeed. Yeah. 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 So all of Conduit's calls are reviewed exactly the same as our own staff. They have 3 call reviews per month, and feedback is given via their performance processes. But yes, the learning from this has already been shared with both employees.
Thank you. I think most of my comments have been picked up, and the one that I would add, which goes back to a pet topic of mine, is the quality of the review, what the call review picked up. And I mean, I thought it was a shame that the call review didn't say for the health advisor, well done for recognising that this needed an override. It wasn't a P3, this was so I think that's a shame. And I think that that one of the issues that this highlights is this the question we were talking about, how long calls take, because the sense was that the health advisor wasn't rushing through, because they really knew that this person should be handed on to a nurse quickly, but they had to go through the motions, and that is not a good experience for the patient. Conversely, the nurse was tremendously unstructured, which was the point that several people have made. It was sort of all over the place. And also, again, a pet topic of mine, I thought that advice couched in what I want him to be doing, I'd like him to ask the doctor, I don't want him to be in pain, is the wrong focus, actually. And it's all about what I, as a health professional, want from you as a patient. And I really think that form of communication is not ideal. It's not terrible, it's not ideal. Okay. Is there anything we can do about Tim's system point? Patients who have surgery ought to have a way of getting in contact with the people who perform the surgery.
Well, I can certainly go back and find, do the demographics and go to the local hospital who perform. But equally, I think there's a bigger system message, and I'll give a little bit more thought to that as where is the best point to take it.
Can I just refer you back to the paper that it's very much in the small print, but in urgent emergency care, it's not just about what 111 can do, it's the more general application of remote and virtual. So it isn't just telephone, it's also web. So does the local hospital that is having a one day length of stay for an nephrectomy patient, do they have good information from their clinical team on their public website that patients can look up, as well as an interactive telephone advice service commissioned specifically for those patients? And that's the sort of thing that people should be doing.
Totally agree. Okay, thank you. I think we're done with the stakeholder section of the agenda, which means that we're into any other business in the public session. Does anybody have any other public business that they'd like to cover? No? Next meeting of the board will be 16th of December here. It'll be my last meeting, it'll be Nick's last meeting. Expect speeches. I know you all look forward to those. Yeah, no, shame, I don't think we're going to do fireworks. Yeah, exactly. That's a message. I want everybody here on time, please, as you always are. All right, I think we should have a 10-minute break and reconvene in private session at 12:05. Okay. Thank you.
Good.